Hello, welcome to your lecture on bipolar disorder. Now we're basically going to talk about bipolar I, bipolar II, and then cyclothymic disorder. They're basically disorders in which the patient has depression, but then also has either mania or hypomania. So we're going to talk about kind of how these might present. Our biggest thing in primary care really is to recognize it. Now they say as many as about 15% of patients that we think have depression actually have bipolar disorder, and that we're not doing a very good job of diagnosing this. And the reason is because lots of times, majority of the time, they come in depression, especially if they come in alone without a family member. And the reason is, if they're in mania or hypomania, they're feeling good. I mean, they're feeling on top of the world. And as far as they can tell, there's really not a problem or an issue. So they're probably not going to see you, at least by themselves, in any kind of manic episode, although that may be the first thing that you see. So you just need to be aware that the presentation and how they come to you really affects how you diagnose, but also, when and how that you refer these patients as well. So the pathophysiology is very similar to what we know about depression, which there is a dysregulation of neurotransmitters, serotonin, norepinephrine, and dopamine. And I have to say, I hesitate to even talk about pathophysiology because what I tell you today is probably going to be outdated tomorrow. There's a lot of research that's going on, and unless you're working in this on a regular basis, you're probably not going to be able to keep up with all the research. Now, of course, if you decide to take care of these types of patients in primary care, which is controversial, you're going to want to keep up with everything that they're doing as far as research in patho. And the reason is, as you know, pathophysiology drives medications. So as you see new medications coming out, that's a good indication for, hey, they may be learning something different. Now, lithium is still our go-to. It's still the gold standard and still the first line of treatment, but there are a lot of other mood stabilizers that are out there as well. And like I said, it's somewhat controversial about you prescribing these in primary care. When it comes to epidemiology, peak age of onset is 15 to 19 years, and then that's followed again by the 20 to 24 year age range, which I think is probably common that we diagnose during that time. And I say that because lots of times these patients will go years without a diagnosis. So it may, be happening when they're 15, 16, 17, but then we're diagnosing them when they're 20, 22, 23. And that's if they're lucky, because we do miss this diagnosis a lot. We've gotten better about it in the last several years. But 90% of the people will be diagnosed by the age of 30 that we're going to diagnose. There's a little bit of a late onset after the age of 60. Of course, you can imagine all the differentials that you would have to rule out to diagnose this after the age of 60. And it is sometimes diagnosed in children. And again, there are lots of differential diagnosis that you would use for children, and I think that this would be really hard to diagnose in a child unless you had a really strong family history. Now, it affects both sexes equally. Females are at a greater risk of rapid cycling, and that's 4 or more mood episodes in 1 year. When we do see it in children, it's most likely going to be reported in boys. Men tend to have more manic episodes, and women tend to have more depressive episodes. We know there's a huge family history, and it's a risk factor. A risk of bipolar disorder is increased by 19% if you have a first-degree relative who has bipolar. Almost all of them will tell you that someone in their family is affected. If both parents are affected, then it's like a 75% chance that the child will be affected as well. Each generation tends to be just a little bit worse than the previous. Now that's not always going to hold true, but it's something that you need to think about. So family history, huge. You've got to ask about that. You need to ask about family history for anyone who comes in for depression. You ask if they've ever had any, history of mania or hypomania, and then you also ask, does anybody in your family have any problems with depression or bipolar disorder or any other, type of mental health issue? So what are your differential diagnoses? Well, that's going to depend entirely on your presentation. If they come in with depression, then of course you're going to think about, getting your CBC for anemia. You're going to think about getting your TSH for hypothyroid. And remember, I said the presentation, most of the time they're going to come in with depression. Now, if they have a family member or significant other or a friend bring them in, then it could be that that's happening during a manic episode. And that's going to just present completely differently. So, depending on whether it's hypomania or whether it's a full-blown manic episode, which is a medical emergency, that's going to affect what your differentials are. We do know that there is a comorbidity with lots of these different things like associated disorders. You have to think about substance abuse, anxiety disorders. Attention deficit is definitely a very big comorbidity, especially, if you're thinking about this as someone who's 15 to 19. So it's going to depend on your patient presentation, their gender, their family history. So a lot of this really needs to be teased out and thought about with your differential diagnosis. Okay, when we talk about bipolar I and bipolar II, we're talking about someone who has mania or hypomania in addition to depression. So if you haven't listened to the depression disorder lecture, it's probably easier if you do that so that you can understand how we diagnose depression. So when we diagnose depression, then we start also asking about these manic episodes or hypomanic episodes. Now with bipolar I, that's the most severe. So you're going to have episodes of mania. And those are going to last at least a week and be present most of the day, nearly every day. And so we had SIGI caps to help us remember depression, and then we have dig fast to help us remember the manic symptoms that we would be talking about. So grandiosity or inflated self-esteem, insomnia, feeling rested after only about 3 hours of sleep. Speech is very pressured, very distractible, a flight of ideas, or feel like their thoughts are racing. There's agitation, or there's increase in goal-directed activity. They take risk. And again, we look at how severe is this. Disturbance is severe enough to cause marked impairment in social, occupational functioning, and it probably is going to require hospitalization. We have to know that the episode can't be explained by a substance or other medical condition. And that's, these are patients you definitely want to do a tox screen on. So that's bipolar I. So remember that you need to have 3 or more dig fast symptoms. 4 if the mood is really just very irritable. And then it needs to last at least a week, be present most of the day, and really cause a marked impairment in function. So this is your DSM-5 for bipolar II. And remember, I always talk about any mental health issue being on a continuum. So you're going to be able probably to diagnose this in primary care. You're going to want to send it off to a mental health professional to take care of it. Diagnosis of bipolar II, you're going to have hypomanic episodes as opposed to a full-blown manic episode. It's not going to last as long, so probably about 4 days, present most of the day, nearly every day. Again, you're going to have your dig fast symptoms. The difference is, it's not going to cause as much of a disturbance in their life. So people who are around them, their friends, their family, significant others, they're going to notice a real change. Like, this is not normal for this particular person. It's very observable by them, but they may be able to still, if they're in school, keep up their grades. If they're working, keep their job. So that's kind of the difference. It's probably not going to mean that they have to be hospitalized. If it's at the point where they have to be hospitalized, then we're probably talking about bipolar I. And again, you're not going to have to discern, is this bipolar I or bipolar II? You need to know enough to be able to talk, obviously, to the family members and talk with the patient and make explanations. But again, someone else is going to help you with completing this diagnosis. Although, because you do know families and you are in primary care, you're going to, be really alert, hopefully, to, which families are, having mental health issues, because there's so much genetics involved. And so, you're going to be a great first line person as long as you're just, really paying attention. I know when we talked about depression, we talked about dysthymic disorder, as kind of just a really low level depression that lasts for years. Well, bipolar kind of has its own little thing like that as well, and it's cyclothymic. It's a very chronic kind of thing. They're going to have numerous episodes of hypomania, but it's really not going to, meet that criteria to say that it's bipolar II. They're going to have numerous periods of depression, but then they're not going to fulfill all 5 of those SIGI caps that, say that this is major depressive disorder. And, they're going to be able to tell you this has really gone on for years. So when you're looking to kind of make this diagnosis, the episodes have to be present for at least half the time, and the individual has not been symptom-free for more than a couple months at a time. And again, they can have major depressive disorder. If they do, then this is probably bipolar II. So, you're just looking for very low level depression and very low level hypomanic. As you can imagine, this is probably pretty hard to diagnose, but it can cause considerable distress and impairment. So, like I said, pay attention. And if you can diagnose this and, send it to a mental health professional, they can get on a mood stabilizer and, be a lot more functioning in their life. So just pay attention for this.
Subjective data, and I'm having trouble talking this morning for whatever reason, so please just ignore me. Do you have mood swings? Are there times when you're depressed and also times that you're very happy and overactive, maybe too much so? Do people ever tell you need to slow down, that they can't keep up with you? Do your thoughts seem to race, go too fast? Have you ever been so happy or excited that people worry about you? Have you ever been so irritable that you yelled at people that you don't even know? Some people, through a family history or their own reading, can be familiar with the term mania, and you can talk about it directly. Use the technical terms very carefully so that you don't give judgmental explanations. Sometimes people are comfortable knowing there is a name for what they experience. Remember that episodes of mania or hypomania are the defining characteristics of bipolar, so you really have to elicit this history. You have to know if it exists, and if it does, then what are the other symptoms? Do you have problems sleeping? In mania, need for sleep is often very much reduced. In depression, there's early morning awakening, but that's a little bit different than, needing to sleep 3 hours and waking up full of energy. So how's your appetite? Disordered eating is very common with both mania and depression, especially in bipolar depressive phases. Appetite's usually decreased in the depressive phase unless it's a abnormal depression and then they tend to eat more. They may even have malnutrition due to poor appetite, especially in the older patients. So be careful about that. Do you ever feel that your life is not worth living? Have you ever thought about harming yourself or tried to harm yourself? Are you thinking about killing yourself now? 20 to 50% of those with bipolar attempt suicide at some point, and 10 to 15% of them die. So the best issue is, just approached just the way that we work through it with depression. Have you ever thought about hurting yourself? Do you have any plan to do so? Ask them if they have any physical symptoms. They may have delusions about other things that are going on, and so that's especially when they come in with depression, if you're not seeing them in the manic phase, but the depressive, when we talked about the somatic complaints and stuff with depression. Do you ever feel that people are against you or want to harm you? Do you ever feel very angry with anyone and want to harm them? So paranoid delusions are common, especially if they're very irritable and intensely manic. So sometimes they get physically or verbally aggressive. You need to know about their support system. Who's helpful to them, who listens to them, who's going to be an ally, who listens to them, but also who do they listen to? Because if you have someone in the office with you who's trying to work with them and they obviously headbutt all the time, that's not going to be very therapeutic and you're not going to get very far. Or sometimes it's an aunt or first cousin or somebody, maybe not the parent, and that's a better situation and they have a better relationship with, so you want to try to find that person if at all possible. They're probably going to need help with compliance and medications. That's a big issue. And then, just asking them, like we do all patients, is there anything else that you want to talk about? Now, hopefully you will have a close relative or friend present, especially if they come in mania, because they're unlikely to bring themselves in that particular state. What you'd want to ask is their family history of bipolar. Of course, we talked about the genetic component, so that's huge. What's the patient's history? Have you noticed that their moods kind of cycle? Have they had this before? Have there been any events or stressors that could have caused this? Recent job loss, divorce, something like that the patient maybe hasn't wanted to discuss? Has the patient ever tried to harm himself? They don't always acknowledge that, but the patient or the family member may tell you that at 17 they did try to commit suicide. Does the patient abuse alcohol or drugs? And if so, what and how much, if they know? What's the patient taken in the past for their condition? What's their current medication? Any adverse effects to the medication? And then, realistically, how much support and supervision can you or other family members or friends provide? So all of these things you really have to get into in this particular situation. Objective data. We've gone through a lot of this already, but you want to note general appearance, bright clothing, excessive makeup, very disorganized, psychomotor agitation. These people aren't going to be the ones who come in and just sit down on the exam table and wait for you to ask them questions. They're going to be up walking around, pacing the room, and show probably some pretty bizarre behavior. They're going to have flight of ideas, easily distracted, and we've talked about a lot of these things. So this goes in the objective data for your part of your psychiatric eval. When it comes to physical, you're looking for any signs of harm. Have they tried suicide in the past? Did they have scars on the wrist? Drug injection sites, if that is within your differentials, you definitely want to be checking there. Injuries or bruises result from alcohol, drug misuse, accidents, those sorts of things. And I think we've talked about the other part of the objective data. Diagnostics really come into play if this is the first time that you're seeing them. It's their first episode of mania. If they don't have a strong family history, even if they do, you want to do a pretty good initial workup. Definitely get, thyroid, CBC, CMP. Of course, you're going to need that information for when you start medications, if you do make the decision to start these medications. ANA and elevated SID rate are just, very general markers for an inflammatory process. HIV and RPR, and these are going to be maybe your people that come in over the age of 30 that you think, this isn't so typical, or there are other things that I definitely need to check out. If it's a 15-year-old, I don't think I'm going to do an HIV and RPR unless my subjective history leads me very strongly to feel like that I need to. Drug and alcohol screen are very important because they do try to self-medicate before they come to see you many times. There's a mood disorder screen, and I have included a couple of those. There's a brand new one out. It's the M3, and I gave you a copy of that, and they're doing lots of research on it. And so I think that one looks pretty good. And then there's a mood disorder one that I also included for you to take a look at that you can use in practice. You want to only think about brain imaging, if they come in and they're an older person. Or, you do a neural exam and you turn up something that is abnormal, but most people aren't going to need a CT or MRI. If they're over the age of 30, especially 40, 50 on up, I may get a scan just to make sure that, especially if they don't have a history of anything at all and it's a sudden onset, then I may scan. I may be more worried about an organic cause. But for the most part, that's not a workup that you would do. A management referral is recommended. Whether it's immediate depends on your comfort level as an NP, and it also depends on the stability of the patient. Of course, you've already learned through the depression that anytime that they have a suicidal plan, and really if they're thinking about suicide at all, with the strong association between bipolar and suicide, I would definitely want to do an immediate referral. Some people start initial medications, and I've given you some literature to look at to think about the different medications that you can use. But at a minimum, you need to know about the medications. You need to know what the usual dosage is, the side effects, and then what monitoring is required. Most of the time, I see these people in practice for a sore throat or something else, and I say, who takes care of this for you? Who takes care of these medicines for you? Are they monitoring your levels? Are you doing okay on these medicines? Those sorts of things, and it's just a very general asking questions. I have initiated the medications before when people came in with a very strong family history and they seem relatively stable. The articles kind of give you a good guideline for when you need to follow up with them, but I haven't done that without also making a referral to the mental health nurse practitioner, Dr. Hart, who works with me and who's awesome. So, and lots of times I'll just call her and say, this is what's going on with this particular patient. This is what they look like today. Do you want me to go ahead and start something? And if so, what would you like for me to start? And when can you see them? So that way I have a good idea of, when she's going to be able to follow up with them and whether or not I need to see them back before she sees them again. And so, it all depends on your comfort level and what your resources are and how far your patients may have to travel, etc. But just if you decide to do the management, all I can ask is please do it well.